there's no other questions, we'll welcome Caleb Banta-Green for today's discussion. Let's give him a round of applause.
So for the first years, do you remember I had you guys look at a movie with the moms who were talking about their kids. So Dr. Green was also Banta-Green was one of the speakers on that video. So just wanted to, in case you thought he looked familiar.
I'm sure y'all watch PBS all the time. Very famous on PBS. So I'm very happy to be here, and I'm going to talk about harm reduction for opioid use and abuse in Washington State. And I'll introduce myself a little bit so you know where I'm coming from. My primary affiliation is I'm a senior research scientist at the Alcohol and Drug Abuse Institute, which is a non-departmental research institute just off campus in the U District. And I'm also affiliate faculty in the School of Public Health and also at the Harvard Injury Prevention and Research Center. And a couple of projects I have to give you a sense of the things I'm involved with right now. I'm in wrapping up year 4 of a randomized controlled trial of an overdose prevention intervention in the Harvard ER that combines brief education, behavior change counseling, and giving people a couple doses of take-home naloxone. So we're looking at whether that has an impact on overdose risk behaviors and overdose occurrence. I run the Center for Opiate Safety Education. I have funding from the State Substance Abuse Agency, and we provide technical support to communities and professional organizations around overdose safety, particularly around naloxone or overdose prevention, but increasingly, you'll hear me talk about it today, around treatment that involves supportive medications, opioid medications. What else do I do? I am contracted with the State Department of Health to analyze the prescription monitoring program. How many of you have heard of the prescription monitoring program? A few of you? Okay, so every controlled substance in the state at the time of dispensing has to get entered into this database. So it's a complete record of all controlled substance prescribing. So I'm working with that data set, looking at opioids. And then I'm also working building some clinical tools for some various folks around overdose education and overdose risk assessment. Those are the main things I'm working on this topic. So before I go on, I guess I want to see people do, this is going to be my rating system of I know nothing, I know a little bit, I feel pretty comfortable about this. So how comfortable do people feel knowledgeable about what harm reduction is? You have to lift your hand up and you have to move it. You don't have to move it, you can leave it right there. So I'll go with sort of low to medium. That's my technical objective perspective there. What about opiates? How knowledgeable do people feel about opiates? I got a couple of hands a little higher, but still kind of medium. Okay, that I'm not going to cover all of opiates, but I will try to give a little more content than I was thinking of around opiates. Okay, so main things I want to make sure that I really want to make sure you're getting what you want out of this. So these are the things I have prepared to talk about. What is harm reduction? Talk a little bit about opioid epidemiology and a little bit about homelessness, particularly how prevalent homelessness is among active injectors. I want to talk about a few different harm reduction interventions, and if we have time, talk about what this means to your work. Before I do that, I guess I would ask if people have any particular questions or things they want to make sure I cover around harm reduction or opiates or drug use or injection or Washington State or anything. Anything? Yes, please.
What's your perspective on marijuana for pain management?
Yes, I will not talk about that. Just kidding, I'll talk about it. I will talk about it.
Just not opiates. Or like it's like an alternative to.
Sure, I'll talk about it. Remind me a little bit further into this, I'll talk about marijuana and pain and all that, okay?
I'll go with this.
Thank you, perfect. Although obviously it might be hard to pull out of the crowd, I don't know. Any other current questions or comments? All right. So what is harm reduction? So it's interesting, I've been having a lot of discussions with a colleague of mine who's a psychologist, and we actually see it kind of differently. You know, I'm primarily a public health researcher, an epidemiologist, and a health services researcher. So I think of harm reduction more like this. And this is from the Harm Reduction Coalition. If you're interested in this topic, they've got a lot of great information. Their website is, of course, harmreduction.org. So the idea is that harm reduction is just a set of very practical strategies and ideas into reducing negative consequences associated with drug use. So reducing negative consequences, not making them disappear. There is a strong component related to social justice and a respect for rights of people who use drugs, and incorporates a broad strategy, spectrum of strategies for safer use. So where you're at, really trying to meet people where they are. It's really easy with this is a topic I'll just start talking about now. We see drugs one way, and we see them very different than we see things like, I don't know, sugar, or smoking, or alcohol. We see drugs somehow as a very different thing, even though they're things that have sort of reinforcing properties that people can use in a destructive way. We see drugs somehow as different. And the basic issue, and I'll say it now, and I would just encourage you to think about this, particularly with opiates. If I use opiates over and over and over and over again, my endogenous endorphin system, it changes. It does not work as well. You start needing exogenous opiates for your endorphin systems to work and for you to feel normal. So you have a change in your biochemistry. You have behaved your way into that state of biochemistry. I made choices along the way that caused that to happen, but once that change has happened, we believe those changes are permanent. People still hope that you're going to behave your way back out of it. And you're not going to behave your way back out of it. You have a biochemical change. So you now need to address that change biochemistry. So sort of think about that as we go along. We have very strong personal beliefs about addiction. I don't know anybody who is not more than one person removed from addiction. We all have really strong experiences, and I think what's important is that we try to spend a little bit of time thinking about how our experiences with addiction personally, or friends and family, how that might shade how we view other people with addiction. We have very good science when it comes to addiction. We have actually the best science and tools when it comes to opiates, but it turns out that stigma and bias and misperceptions guide most of what we do, not actual science. So I will try to present some of that science to you. Okay. So this is kind of this almost philosophical approach to harm reduction, and I went to social work school 20 years ago, and it's kind of like that. It's using a strengths perspective, it's meeting people where they are, it's all these various terms, and harm reduction kind of falls within that. And I just want to mention this type of work. Don't worry, you don't have to read that. But just to know, if you do get interested in this is really important. So Susan Collins is a professor here in psychology, and she does really interesting, exciting work. And as a clinical psychologist, she really thinks about harm reduction as a clinical intervention, a way of relating with people that follows those same principles, but is very specific about helping patients basically identify what are the things they want to work on and then facilitate that. And not you railroading them into what you think is what they should be working on, but really what are they willing to work on? What are they capable and able to start doing? And her work's very interesting. She does a lot of work at 1811, which is a facility downtown near REI, right next to I-5. It's for chronic public inebriates. It is a housing first model. So you get people housed first. It is a wet house. People are allowed to drink. And then, once their life is at least stabilized in terms of housing, you can start dealing with other health issues, including their alcohol use. So housing first is a type of harm reduction, if that makes sense. And very oftentimes, I don't know how much, probably most of you don't have much experience about how addiction is treated, we generally say things to people either in medicine, or psychiatry, or homelessness, or housing, oh, you need to stop using, and once you're clean, then you can get food, money, housing, whatever it is, when you're dealing with somebody who's addicted. As opposed to saying, we're going to try to get you a little bit stabilized, and then we can deal with the addiction. Just trying to turn that around. Okay. So I just wanted to mention Susan Collins' work. She's actually got some really nice chapters in some books that are available online if you're interested in learning more about sort of the philosophy and the practice of what harm reduction looks like. So just around opiates. So just to jump into opiates, and I've been around for most of this in Washington State. So this is what's happened in Washington State is just a couple years ahead of what's happening in the United States. So I'm going to talk about Washington, but it's very representative nationally. So in 1996, the state medical board said that we're under-treating pain, chronic non-cancer pain, and we should use a lot more opiates. And we did. We started using a lot more opiates, and I'll show you those data in just a moment. In 2003, the state Medicaid actually took OxyContin off of the formula because they were all worried about OxyContin back in the day, and put methadone on. Methadone is a long-acting opiate, very potent opiate, can be very good medication if it is used properly, and it can be very dangerous and deadly medication if it is not used properly. And thousands of people ended up dying in our state, probably because the prescribers were naive to using methadone. They didn't understand how to use this medication. Okay, so the first kind of chronic pain guidelines came out in 2007. Dr. Gary Franklin, who's the medical director for labor and industry, was seeing his his pain patients come in with a bad back and dying of opioid overdoses 6 months later, and he was extremely concerned as the medical director and as a care provider. So he started working on pain guidelines to really try to At first, it was really just to rein in opiates. That was really the goal. And I think more recently, it's evolved more into what are sort of complementary or alternative treatments that we can be involved in and pay for. It's really quick and easy to pay for opiates. It's not as quick and easy to pay for psychotherapy and physical therapy and weight loss and smoking cessation and all those things. The pill is the ticket for the doc to move on to the next patient. So it's been very easy and it was incentivized for a long time to prescribe opiates. And it was in fact a mandate from the state medical board. 2010, OxyContin has changed. It can't be crushed anymore. And it was really the Gucci. It was the drug that people wanted. And I actually work with state police, and we look at what evidence is sent to the crime lab from police officers, and OxyContin just disappeared. And that's really the main driving factor behind the decline in the availability of illicit prescription opiates on the street. It's really OxyContin getting reformulated. That's the big deal, because people wanted OxyContin. And then we also had a general reining in of prescribing. We had the pain guidelines that came out in 2007. In 2012, they were actually enacted into law around chronic pain. Basically, the idea is that if I'm a provider and I'm seeing a patient and they're up to getting to 120 morphine equivalent per day, that's the time that they are suggesting you get a specialty pain consult. They're really trying to look at dose. They last year expanded to looking at acute pain. They also started talking about you should consider co-prescribing naloxone for people who are at higher risk for overdose. Naloxone is a pure antagonist to opiates and blocks rapidly overdoses. It takes effect in 2 to 3 minutes, lasts 90 minutes. That's what naloxone is. And in 2012, the prescription monitoring program became available. You'll hear a lot of sort of spurious claims that, oh, the prescription monitoring program is gaining in opiate prescribing. Opiate prescribing, as you'll see, started declining around 2009, 2010. So the PMP is a great tool as providers. I would strongly encourage you, when you see a patient for whom you may have to prescribe opiates, to check the PMP. It's worth it for you to know if they've gotten OxyContin at 3 different ERs in the last week. That might inform how you want to care for that person. Or if they've been on benzodiazepines for 3 years. That's kind of relevant clinical context. And I'm, of course, being facetious because it's incredibly important for patient safety. It's a really important tool. Okay. So, prescription monitoring program is, right now there are no mandates for people to register for it or to use it in Washington State. However, as practitioners, you can register for it, and I would encourage you to use it, and you can actually delegate other staff to check the systems for you. Any questions about any of that?
I think the rate of dentists who belong to that is a little low, isn't it?
I don't know the rate. That's a very good question. I don't know the rate of dentists. I will tell you, among all licensed providers with a DA license to prescribe controlled substances, it's 32%. And we did a study last year looking at people with elevated risk for overdose, and it was only 50% of their providers were even registered for the PMP. That's just registration. That doesn't mean you use it. So yes, it's in my opinion far too low. It's a very useful clinical tool, and it cleaned up a lot of the processes. It had like 2-factor authentication. It was a pain in the butt to use, but I think in the context of for a fairly planful dental practice at the beginning of the day to look at the patient log for the day and check it quickly seems to me a plausible thing to do, as opposed to in a more acute care setting where it reasonably could be quite a pain. Please.
Why do you need this monitoring program since the pharmacy already get approval to dispense to the patient, so they must have the record already in some central bureaucrat agency, right? So why do you need voluntary practitioners to sign up to show the record who's taking what?
Sure, great question. So why have a practitioner sign up for the PMP? So pharmacists are required to interdispense medications, but they're not making prescribing decisions. You're making a prescribing decision. And so the idea is that when you have a new patient come to you, particularly a patient you don't know, you can check the system and look at their controlled substance history to understand, do they have a history that, one might tell you they're opiate tolerant. That might be helpful for if you're going to be doing surgery. And also if you're going to be dispensing medications, to understand, does this person have a history of using these medications, or are there even indications that potentially they have a history of misusing the medications? So the point is that your point of care about when you're making a decision to dispense, administer, or prescribe an opiate, it's helpful to have that information there, not just sitting at the pharmacy. Does that make sense?
Can you directly go into the pharmacy record though?
Yes. So if you're the medical provider for somebody, you can go into the prescription monitoring program for your patient and look at all controlled substance prescribing since 2012. Yep.
Is the PMP something you have to pay to be a part of?
No.
To register for, or is it
No,
free?
registration is free on that. Yes?
But is there like a political push to make this more like mandatory, or is there, what's the status of that right now?
Well, I've been working with several legislators on bills related to that in the last week. There's interest in it. It's not going to happen this year. I have a colleague, Dr. Greg Turman in anesthesiology here, who had a piece, he had an editorial at USA Today, and his point is that at this point, he thinks it should be mandatory, in his opinion, for people to register for the PNP. He doesn't think the system, and I agree with him, that the system is not smooth enough yet and accurate enough yet that I think it's fair to make everybody use it. I think it will be cleaned up over the next few months. I think it will be at that point. But the system is incredibly complicated. It's got tens of millions of records, and the system is still, it's not a beautiful, a seamless tool that beautifully fits in your care to the point where like, this is such a great tool, you have to use it. We're getting there. I do think some states have required utilization of PNPs. Last week, there was a piece in the law that basically said, if you're prescribing a Schedule II, a C2 for chronic non-cancer pain, you must check the PNP. That got stricken immediately, mostly because I said to them, there's no way to objectively determine if there's chronic use. There's no way in the way the system operates right now to make that determination. They wanted you to check the PNP before the first prescription for chronic pain. That transition is incredibly gray when a provider moves from providing acute care to chronic pain. Is it month 3 of getting OxyContin for my back? Is it month 6? Is it a dosage? Is it day supply? What is it? So we're not quite there yet. Yeah? Is there another question or comment? Okay, I'll keep going. Okay, this is a little bit old, but you get a sense of it. So this is basically opioid prescribing in Washington State. This is daily dosage. So this is a World Health Organization measure. It's kind of a weird measure, but it's the total number of daily doses. So for instance, the top blue line is hydrocodone. That's almost all Vicodin and ibuprofen. So 45 million daily doses in Washington State. That's a lot. The red line is oxycodone, and what you see there is that it really is leveled off in 2009. It's actually declined a little bit since then. So oxycodone is one of typically formulated as as a short-acting medication, but it can be formulated in long-acting form. That prescribing is really leveled off. Fentanyl and green. Codeine has actually come down a little bit. And what else is up here that I want to point out? So methadone isn't up here for various reasons. The data are weird, but basically a very similar pattern for oxycodone. Oh, I'm sorry, the other one I want to mention is morphine, which is purple, at about 7 million. So morphine, oxycodone, and methadone as the main medications that are used in long-acting formulations, potent medications, those have all leveled off, and actually prescribing writ large has declined a bit over the last couple of years. So we've seen opiate prescribing go down a fair amount. Just to give you a sense of what prescribing actually looks like, there's really acute prescribing, less than a 90-day supply, and long-term prescribing. And this is just, these data are preliminary. In fact, they're incorrect, but they're on scale. So what you see is that in 2013, you had 1.3 million people in our state of 7 million get essentially an acute opiate prescription, and about 200,000 get opiates long-term, ongoing. And you can see that the number of prescriptions was 2 versus 14.5. And really importantly for the long term, 46% got a sedative medication, either a sleep med, a muscle relaxant, or a benzodiazepine, concomitant at some point with that opiate medication. That's a substantial increased risk for overdose if you're co-prescribing this, if you're using those medications together. So this is what's on the street. This is this police evidence I talked about. So the green line is all opiates overall. The blue line is heroin. You can see we had heroin certainly back in 2002, fairly low levels, and it has increased dramatically in the last couple of years. And you can see prescription opiates increase, this orange line, and then hey look, they decline right as the availability for prescribing declined. And the point is that opiates prescribed are, certainly people use their opiates, of course. They may have extra supply that they sell or that get stolen, or they may actually wantonly be going around and doctor shopping and getting illicit meds. So generally, tamping an opiate supply does bring down opiate illicit availability on the street. Really importantly, we don't have time to get into it in a lot of detail. I do think it's important for people to have pain control, and opiates have good efficacy and effectiveness for acute pain control. It turns out that they're not so great for chronic pain. And that's a really big pendulum shift. So I do think it's important, if you're ever looking at these data, you want to ask questions a little more specifically than just, are all opiates up or down, and is that good or bad? There's different types of prescribing, different medications, different indications, different settings, where there may be a very good rational use for opiates, and there may be settings where it's not such a good idea. So really quickly here, this is treatment admissions in Washington State. This is the primary drug that people came in for. The top blue line is alcohol. I put that up there to say that it isn't as though these data are indications just of alcohol use or alcohol abuse. That's been obviously quite steady generally over time. So these data are strongly influenced by funding and also availability of treatment slots. What I want to point out though is in green is heroin treatment admissions. So a huge increase in heroin treatment admissions in Washington State. And the orange line, that other, is actually prescription opiates, showing the exact same pattern, the exact same temporal pattern as we saw for opiates off of the street. It's much, much harder to get prescription opiates off of the street. And what you'll see in a moment is that for people who are abusing or addicted to pharmaceutical opiates, and they can't get them, and you don't get the medication-assisted treatment, they're going to use heroin. That's what they do. The brain, if you, I spared you the chemistry, but if you guys would eventually be able to see, there is a difference between diacetylmorphine, which is heroin, and oxycodone, but it's just like a hydrogen and a carbon. They're basically identical, and that's on purpose because oxycodone was formulated and made in a laboratory to look and work just like heroin. They are the same thing to your brain, so they are perfect biological substitutes. The thing is that heroin is much more widely available and much, much cheaper. And then just this little bit here, this is people's first time ever coming into treatment and how old they were. This is across Washington State. And the red area there are ages 18 to 29. And so that's what's driving all of this, is this 18 to 29-year-old group. And what's really important is opiate addiction is a chronic medical condition. It's a lifelong condition. So these are folks who are going to either, they're going to be using opiates in all likelihood in some form over the course of their lifespan. I would argue that medically we'd like to be giving them good medication-assisted treatment rather than them injecting heroin 4 to 6 times a day. So this is a really big demographic and epidemiological component of what's going on, and it's really driving this long-term need for extended treatment, and it just means you're going to have a lot of patients out there who are opiate addicted. There are just a lot more of those folks. We think, actually, come right back to you, the data I'm not going to go into detail here is we've been asking high schoolers how to use prescription opiates to get high in the last month, and that number has gone down from 10% to about 6%. So that's gone down. We're kind of stopping the incidence. Hopefully, this number is going to come down in terms of new young people coming into treatment, but that's a huge bolus of people that are still going to need care. There's a question or comment?
Yeah, this is it's in Eastern Washington. Is it pretty similar for Western Washington, or is it?
So I took out all my Washington State maps, sorry. So this is, we've always had it up and down I-5. We've had this in Grays Harbor for a long time. We've had it to some degree in Spokane and Yakima. It is a bigger problem in Western Washington, but it certainly is a problem in many parts of Eastern Washington. Last year, I hosted 2 different forums for professionals. One was here at the UW. We had 400 people come and hear about opioid overdose and blah, 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 blah. And then we said, oh, let's do one in Ellensburg. And then we only had a room that was about a little bigger than this, 200 people, and it filled up in like 3 days. Like, there's tons of interest and demand from police and medical professionals and community activists and public health people to do something about this. So I can show it with the data, and I can also show it with how many people show up in a room to learn more. Yeah. I mean, I have a map coming up. So drug overdoses. The top line is all opiate overdoses together. This gray line is pharmaceutical opiate-involved overdoses. Again, the exact same temporal pattern, leveling off in 2009, 2010, and coming down. And you can see heroin making up for that completely. So we're actually flat over the last 6 years. And we have 2014 data. I'm sorry, these aren't up here. But you see the same pattern. Prescription opiates down a little bit, heroin up a little bit. So the net effect, although we've done all this work on prescription opiates, the net effect in terms of opiate overdoses is flat. Any questions about any of that? All right. Don't worry, I'm not just Dr. Doom and Gloom. The cool thing is there's lots of things we can do, except I forgot that's my Doom and Gloom slide. Sorry. There's your Doom and Gloom slide. That's the 7,834 dead people in our state and where they lived at the time they died. So it's a lot of people. This is a huge issue in Washington State. Okay. So we actually did something this last year. We did a statewide syringe exchange survey. There's about 20 syringe exchanges in Washington State. I guess I'll say a little bit about syringe exchanges first. How many people, okay, I'm gonna do a syringe exchange poll. How many people feel like they know how much about syringe exchanges? We got one arm way up. A lot of people are nodding off. We got some people in the middle. Just giving me a hard time. So really just to remind you, syringe exchanges is basically exchanging a clean syringe for a dirty syringe. And it actually started in Tacoma in 1988. And it is an extremely effective way to prevent HIV and prevent hepatitis C. And it's also, it turns out it's a great way to engage with people who are injection drug users and build trust with them, people who are generally often having mental health issues, a lot of health issues, and come from a place of trauma. It's a very safe place for people to go, so that after they've been coming for a few months, and you've been mentioning to them, if you're ever interested in treatment, let me know. Maybe in month 3 or maybe in month 20, they're like, tell me a little bit more about treatment. I think I might be ready for that. So it's a good venue to do that type of care. And I'll mention that we have one of the lowest HIV incidence rates in the country among injection drug users. It's phenomenally low, and it is exactly because we've had syringe exchange since 1988. Very different than New York City, where we have much higher HIV incidence among injection drug users because they didn't get syringe exchange till they did. So we did the survey at Syringe Exchange, and I'm not going to go through all of this except to say that these syringe exchanges that we surveyed represented 11 million of the more than 14 million syringes that were exchanged in Washington State in 2014. So we have more than 14 million syringes exchanged in Washington State. That's enough for about 15,000 people to have a syringe in it. And just as an example, these are services, are great places to work with folks, and they are very threadbare. So I like to use the example of Grays Harbor, which is kind of right in the middle. They're open a day a week, they're open 4 hours a week, and they exchange 750,000 syringes a year. So they're doing a lot of volume. And just to give you another sense of sort of the on-site services the syringe exchanges provide, 11 do HIV and or hepatitis C testing, 7 do wound care, 7 do case management, Apple Health enrollment, vaccination. You get a sense that there's a lot of other things going on at the syringe exchanges. Any questions about what are syringe exchanges and what they do? Okay. And the idea, of course, also in the harm reduction concept is that, well, you could not give people clean syringes and they could keep sharing and using syringes, and I guess, some person would say we did the right thing, we didn't enable drug use, but the people are going to be dying of infectious diseases. So it's this idea about let's engage with people and try to reduce the harm that's going on here. And so this survey, we did 18 syringe exchanges, we surveyed over 1,000 people. I say we, I mean my center and my staff helped facilitate this. My staff went out and helped do the surveying, and then we're analyzing the data now. And the color coding is by syringe exchange. So the red is the King County Syringe Exchange. The purple is the Thurston County Syringe Exchange, and this is where the people live. We use that exchange, so they actually are serving about a 6-county region. You get a sense of where people are. And some of these exchanges, like in Kittitas and Ellensburg, they just had no staffing. So when they got their four people who they were able to get surveys for, they just didn't have enough staffing to do survey. Okay. So a few things I want to point out here. One, I think people will have a certain image of who is an injection drug user, usually an old man. And that's not necessarily the case. So 43% female, a third under 30, a third in their 30s, and a third 40 and older. And 82% white. I want to be really clear that people could use multiple race responses, ethnicities. So it's not just white, but people have multiple responses. But like our state, the majority were Caucasian, but we certainly got substantial proportions of people of other races and ethnicities. And then housing status, and then we actually see this is pretty uniform across the state. This is not just a Puget Sound finding about homelessness. So 38% are permanently housed, 34% report being homeless, the remainder being impermanently housed. Another really important point here is 39% have been in jail or incarcerated in the last year. That matters for a lot of reasons. One, it's not good for your future economic viability and social standing to have an arrest record. It also is an interruption in your tolerance if you're an opiate user. So it's a huge risk factor for opiate overdose is being incarcerated. We have lots of good data on that. And then you get a sense of income. You have 75% of people are below 139% of federal poverty level. So that may not surprise you. Age of first injection, you can see the distribution here. The mean age is 24. The mode is actually 17. So you get a sense that this is really happening across the life course for folks. Most people, it's in their teens or their 20s, but it's not just those age groups. this is a question that I first wrote in 2009, which was, were you hooked on prescription opiates before you began using heroin? And in King County in 2009 it was 39%, and now statewide it's 57%. So you can see the age distribution. The normal way, the typical way for young adults to come into heroin use is through using prescription opiates. Any questions or thoughts on that? Primary drug is heroin, 22% methamphetamine. There's a ton of clean, pure, I shouldn't say clean, well, it's very high purity. It's 99% pure methamphetamine coming up from Mexico. Mostly in this group, these are injection drug users are injecting. Meth and heroin together, 5% reported it as their primary drug, but about 35% reported it as something they've done in the last 3 months. There's a new thing, is meth and heroin getting injected together. And very small proportion saying prescription opiates are their primary drug, because you just can't get them. 14% are currently in treatment. Most of those folks are on methadone maintenance treatment. And do you want to get help reducing your use, reduce or stop your use? We very purposely did not ask people, do you want treatment? Treatment is hard to get. There are lots of rules. There are lots of requirements. A lot of those rules and requirements are barriers for people getting into treatment. So while they may prefer to be on buprenorphine or methadone as medications, they don't want to deal with the system and bureaucracy and the clinical setting and all the requirements of getting on those medications. So basically 24% said they had no interest in getting help reducing their use, 43% very, 24% similar. The idea is that, I'm trying to present this in contrast to the idea that somehow heroin users are all having a great time, getting high. If they could just get enough heroin, they would just keep using heroin. The majority of folks don't want to be using heroin. They would actually like to get help reducing their use. So how many have had an overdose? 19% have had an overdose in the last year, and I don't know how much statistics you've taken. We would call this survivor bias. Of course, the dead people can't answer this question. So the annual overdose rate for an opiate user is going to be more in the low 20s. And how many overdoses? You can see most had one, but a number of people had multiple overdoses. How many have witnessed an overdose? 54%. About half the time they call 911 when they witness an overdose. And have you had naloxone? So naloxone is an antagonist. I may or may not have time to talk about it more. It's an antidote. 2010 law basically allowed prescribing and dispensing naloxone to anybody at risk for having or witnessing an overdose. 45% of respondents in King County have had naloxone in their possessions in the last 3 months. Much smaller numbers outside of King County and in eastern Washington. We actually, as a result of getting these survey data and sharing with the state, we got a pot of money to buy about 1,000 doses of naloxone that was distributed to the rural needle exchanges to try to get those numbers up. Any questions so far on sort of overdose, naloxone, syringe exchange? So the short way to say is a super high acuity group. What's interesting is 86% are insured. So that's a new thing, that there's that much insurance for folks. So that represents some really big opportunities, particularly in the Affordable Care Act. April 1, we have behavioral health care organizations moving to a managed care model for all mental health and substance abuse. There's a lot of opportunities for care for folks, and there are actually some novel ways getting explored about how do you provide medical care, not just in a medical care setting, but at a syringe exchange in a community-based setting. You're providing medical care, it would be nice to get reimbursed, otherwise it's not going to continue to exist. So there's a lot of financing things are getting figured out right now. Usual place for care, clinic or doctor's office was most common, 44%, and about a third ER. If you ask if you've been in an ER in the last year, at least a half of folks have. Yeah?
So does Medicaid not cover drug abuse treatment?
Okay, so, well, let me talk about drug treatment a little bit. I don't know where I am in my slides yet. So, Medicaid does pay for drug abuse treatment, kind of. So for opiate addiction, the gold standard treatments are agonist medications, methadone or buprenorphine. Methadone is dispensed in large standalone clinics. It's very tightly regulated. They're big standalone clinics that might serve 350 or 700 patients. They have to come in and dose 6 days a week initially. It's a very intensive model of service. It actually comes out of Harlem, and we're a very geographically and population dense place. That kind of makes sense. Not such a great model as there's many more people and people are spread out. So that's one model, and then most of the methadone programs are full. There simply isn't capacity. There's workforce issues, they don't have enough people to staff those clinics. So methadone's pretty much full, Medicaid certainly pays for it. We have more than 10,000 people on methadone maintenance in Washington State. Buprenorphine is another medication. Buprenorphine is a partial agonist. It binds to those opiate receptors, turns them on partway, has a ceiling effect. So you can't get very high on it, and you cannot overdose on it by itself. If you add sedatives to it, you still can. It's a safer medication. So it's Schedule 3, even though methadone is Schedule 2. So buprenorphine is Schedule 3. It can be dispensed out of opiate treatment clinics like methadone in a very similar way, or it can be written by a physician, only a physician, it's federal law, not a nurse practitioner, a physician can prescribe buprenorphine out of their office. They can see 30 patients in their first year of having a DEA waiver, 100 patients thereon. So that's another model. There is Medicaid coverage for buprenorphine. They just expanded that coverage. The real issue there, and I've done a lot of work actually with the family medicine and rural medicine departments, is you've not nearly enough prescribers who are willing to even do buprenorphine and care for people who are addicted, or to care for more than a handful of patients they already have. They don't really want to take on this population and work with it. I want to share that there is a couple of my colleagues in adult medicine at Harborview are working on a model and implementing it here that came out of Boston. That's a nurse case management model that puts a lot of that onus onto a nurse case manager, which medically is totally fine, and I think is making a lot of docs more comfortable and willing to do that type of prescribing. So that's the medium-length answer to that question. Okay, great. I'm going to keep plugging away here a little bit. So primary healthcare concerns, so not necessarily what you'd think. 31% said some type of drug use related issue was their main healthcare concern. 54% said not drug use. You can see here we had 6% said dental, so 60 of these folks had dental as their number one healthcare concern. But there's a whole range of things. I'm actually just going to stop talking for a second so you can just see the range of things that people talk about. These are really complex medical patients, extremely. So opioid overdoses, I've talked a bit about this. Let me talk a little bit more. So there's a lot of harm reduction approaches out there around opioid overdoses. Obviously they can be prevented either by not using opiates, which if you're opiate addicted is not the number one choice. But there are ways to reduce use if you are going to use opiates. Really low knowledge around overdose and how to prevent it. There's a lot of issues around fear of calling 911 during an overdose. And the point is there's an antidote. Take on naloxone. Efficacy is great. There's good effectiveness, very good effectiveness is improvement in population level studies around reducing mortality if you distribute take on naloxone to heroin users. So there's a good evidence base. So we need to kind of spread the word. There's been a lot happening on this topic. Again, I've been working very focused on this topic since 2001, and it really is almost an exponential increase in the amount of knowledge there is around overdose and around take-home naloxone. So just this general idea that overdoses can be prevented and reversed, to let you know that 1 in 5 adults is prescribed an opiate every year. Most of that's for acute pain. Most people don't take it all. Most people keep it, it's just stockpiling in their homes. There's just a lot of opiates out there. About 10% of adolescents are prescribed opiates. The main places they're getting prescribed opiates are dental procedures, upper respiratory infections, and sports injuries. So we'll come back and talk another time, and I'll need to bring a real MD with me and talk about prescribing opiates for dental procedures and when it's actually necessary, and the amount that's necessary and the type of medications. But that's a really important issue. It is more than anecdote, the number of adolescents that got Vicodin or OxyContin with their wisdom teeth extraction, maybe used 1, 2, or 3, and took the other 27 to a keg and shared them. And that's normative for what happens with those medications. So the idea is people should get overdose education, right? And if you have opiates in your household, they're an overdose risk for you and anybody else. And I think what's really important when talking with patients is to identify that we're talking about these medications. They are inherently dangerous. I'm not saying I don't trust you. I'm saying I don't trust opiates. Depending on the person's background, they may be fine with that. But if they have an addiction history, or they have any concerns about their use, they can also be very defensive. So it's important to know that and know that person's history and really frame it as about the medications themselves and less about, well, I'm worried about how you're going to use them. Opiates are just dangerous. They're just dangerous. They are. They can be used safely, but they are inherently dangerous. And we actually have, I don't have it here, but there's a nice flyer on a Take As Directed. So the Department of Health has something called Take As Directed website. We have a really nice 1/3 sheet that we actually kind of made for pharmacists, but you guys could certainly hand it out, that is about how to keep yourself safe and other people safe when using opiate medicines. And it's very medically framed, but I think it's a nice conversation piece to talk about opiates and overdose potential. Okay, so I'm gonna keep going. So, medical providers can obviously prescribe to folks. I mean, I'm not a person who believes that every single opiate prescription should have naloxone go out with it. That just seems a bit excessive to me. I think any regular user of opiates, whether it's heroin or prescription opiates, should absolutely have naloxone in their home. That doesn't make sense to me. You have things in your home that could catch fire, so you have a fire extinguisher. You have opiates in your home regularly, you should have naloxone. It just makes sense. So insurance is covering it. Medicaid covers naloxone in different formulations. We actually have rules in Washington state that allow pharmacists to directly prescribe and dispense naloxone, just like they do flu vaccines. It's called a collaborative practice agreement. So we have pharmacies doing that. And then the idea is that ultimately you can get to reimbursing folks for doing their overdose education. I'm just going to do one or two more things. I think I'm going to stop here on this slide. As I mentioned, I think all chronic users should get overdose education in naloxone. We did a lot of work with our overdose trial. We actually had a bear of a time recruiting prescription opiate users and abusers in the ER for two reasons. One, there were almost no prescription opiate abusers because they couldn't get them anymore. And I talked to the attendings, I believe, 4 times. They never really understood that I was talking about people who are taking opiates prescribed to them are at risk for overdose. Whenever I said overdose, whenever I said naloxone, the image that leapt into their mind was heroin user. Even though there are tons of people using opiates coming through that emergency room and are dispensing tons of opiates. So there was a low risk perception on the provider side in terms of opiate-related risk, and it was incredibly low risk perception on the patient side. They couldn't conceive how if they were taking the medication prescribed to them, how that could possibly be dangerous. So we did a lot of work with them, and we did a lot of changing of our message, going from, oh, save a life, learn how to prevent an overdose, yada, 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 to just in case. Because people were talking about EpiPens and fire extinguishers. We were listening to patients. And the types of language that sort of is when they clicked and got interested and engaged were those types of messages about kind of just in case. I might as well have this as backup. I might as well have that. So I think I'm going to stop there rather than try to cover more content, and I would welcome any questions or comments.
Is there depression screening that goes with this? Because how many are like suicides versus accidental?
In terms of overdose? Overdoses with opiates, about 85% are accidental. About 15% with pharmaceutical are suicide, and a very small proportion of heroin are suicide. Yeah. And actually, you would be thoughtful, and we had to be thoughtful in our study. We didn't enroll people with any suicidality because we were telling them what things cause an overdose, which is probably not really what you're going to tell somebody who's actively suicidal. You may want to talk to their family, but that may not be the person who do that education. So other thing, I guess on that front, I just want to mention is we have a website, stopoverdose.org, that has online patient education. It is information for prescribers and pharmacists about opiate overdose and about different ways to respond to it. That is an example of harm reduction related to opiates that I just wanted to share with you. So I'll stick around a little bit. If you have any questions, I'll be here. Thanks.